Hi, my name is Rob Daigle. Today we'll be talking about hemodialysis access graft evaluation with color Doppler ultrasound. Hemodialysis access fistulas and grafts present a unique challenge to the vascular sonographer. Each of these grafts is different situations and sites within different patients, so we have to approach this exam with our thinking caps on. And it's actually one of the more interesting exams I think we perform in the vascular laboratory because of the different hemodynamics that we see in the veins and the arteries as a result of these grafts and fistulas. Let's do a brief overview of what hemodialysis access is all about. Hemodialysis access is created to sustain patients with end-stage renal failure. There are approximately 200,000 to 400,000 patients in the United States that are dialysis dependent. So these patients are often waiting for renal transplantation, or many are not available for transplantation, so they live the rest of their lives on dialysis. The different types of access are the central venous catheter. This can be inserted into the internal jugular vein or the subclavian vein, and there's basically two types of these. One is a temporary short-term solution. This is often performed while the fistulas or grafts are actually maturing prior to use. Or these can also be tunneled as well underneath the skin for a more permanent solution. Native access fistulas are the next type of access. Arteriovenous fistulas are created. These are usually performed in the non-dominant arm, and they can be created in two fashions. One is considered the end to side assessment, which is the more common. Here we see the cephalic vein being anastomosed into the radial artery to create a arteriovenous fistula. This other diagram indicates a side-to-side anastomosis, and we see this less frequently in the forearm, but more commonly in the brachial area. The advantage of these arteriovenous fistulas is that they are autogenous, and they're known for their long-term patency. They also have a very low complication rate compared to synthetic graft material. One of the more common fistulas is created in the radial artery to cephalic vein. This is called the Breccia semina fistula. These fistulas can also be created on the ulnar artery to the basilic vein. Another common site is the basilic artery to median cubital vein or to the basilic vein. Again, these are direct communications between the artery and the vein. Now the fistulas with maturity become almost sausage-like. They become very dilated, particularly just past the valve cusp, and these are superficial, so the effect is sort of a lumpy course of the arteriovenous fistula through the forearm. This makes it very difficult to obtain flow within the fistula itself or the vein portion of the fistula. Transducer contact is also sometimes difficult because of the tortuosity or the uneven surface that we have to place the transducer on. Now a different third type of access is the bridge graft. This is used when veins are inadequate. When the fistulas have failed, sometimes the surgeons will go to these grafts as well. About 50% of patients are not candidates for arteriovenous fistulas, and this results in synthetic grafts being surgically implanted. So the graft actually is the more favored method in the United States, although in other countries, for instance Europe and in Asia, the arteriovenous fistula is the more common. So for the access grafts, a synthetic tube is placed in between the artery and a superficial vein. And these can be placed in one of two situations. It can be a straight course of the graft, going in this case from the radial artery to the median cubital vein, or these can also be in loop positions. This is a very common one that we see. It's the brachial artery. The graft loops down through the forearm and courses back to the median cubital vein or to the basilic vein. And then occasionally we see this anastomosed into the cephalic vein as well. The diagram on your right shows a different type of a graft. This is a reversed graft. The graft comes from the brachial artery and is anastomosed distally into the basilic vein. So this is this gives us a line of, or an access for multiple punctures. One of the advantages of the loop graft is there's actually more sites available because it's a longer length of dialysis access. The different materials of grafts for the access graft, the most common one is polytetrafluoroethylene, or PTFE. This is just a Teflon graft. On ultrasound, this has a double wall appearance that's very characteristic of PTFE, not only in hemodialysis access grafts, but in lower extremity arterial grafts as well. The diagram on the left here just shows a Teflon graft that was in as a loop format. Now there's another type of graft that's that's coming into the area now that's becoming more popular, and this is a polyurethane graft. This is also known as a vector graft. It's made of Thorilon. And one of the interesting things of this graft is that it can be used immediately. There's no maturation period involved as there is with PTFE. It's also self-sealing, but it's important to note that this graft is impenetrable by ultrasound. So when we try and evaluate this type of graft, we can't get any ultrasound through the graft, so we have to assess the inflow into the graft and the outflow to determine any stenosis or occlusion within the graft. Now the arterial venous fistulas versus graft, the patency rates, this is just a diagram that demonstrates patency rate over a number of years, in this case 5 years. We see from this diagram that the fistulas have a much longer patency rate and a much higher patency rate compared to synthetic graft material. Now the colored duplex evaluation of the grafts consists of two parts. One part is the preoperative assessment. This will entail evaluating the arterial and the venous system. Part 2 involves examination of the functioning fistula or bypass graft, and this occurs after the graft is being used after the maturation period. Now, why do we perform pre-op mapping? Well, this diagram that was presented in a paper in the Journal of Vascular Surgery a couple of years ago demonstrates nicely the experience with this group. This is pre-mapping. This is prior to this group performing arterial and venous mapping prior to the implantation of the fistulas or grafts. They had 14% of their fistulas of new access were performed, but after they began mapping, the number of fistulas climbed to 63%. The early failures prior to their mapping, arterial and veins, was 36%, and their failure rate dropped to 8% as far as early failures involving the mapping procedure. 1-year patency rates were also quite a bit higher for those patients that they scanned preoperatively. So there's a compelling reason to study the suitability prior to the surgical procedure. The preoperative assessment of the arms entails the arterial assessment. This includes scanning the brachial artery for obtaining brachial pressures. So using a stethoscope or a Doppler, we obtain pressure on the right side and the left side, and these should be within 20 millimeters of one another. If there's a greater than 20 millimeter difference, that can indicate the presence of subclavian stenosis, and that needs to be evaluated further. Arterial lumen diameter of the brachial artery or the radial artery should be 2 millimeters or greater. There should be no significant arterial stenosis through the brachial and the radial or ulnar sections. And also, the palmar arch should be patent as well. We'll come back and review the evaluation for this part of the anatomy in just a moment. Also, it's important to note any unusual anatomy. For instance, if there's a high confluence of the radial artery and the ulnar artery, this should be noted, and it's helpful preoperatively. As far as the venous evaluation, we determine whether the superficial veins are available. There's a lot of variation in anatomy in patients. Sometimes these veins have been harvested for other procedures, other vascular procedures. So we'll scan these superficial veins and make sure they are appropriate. The luminal diameter of 2.5 millimeters or greater is useful for the arterial venous fistula, and for grafts, these veins should be at least 4 millimeters. Also, there should be no venous obstruction or venous thrombosis, and also absence of central venous stenosis or thrombosis is important. Let's review the anatomy very briefly of the upper extremity. Here's the arterial anatomy. This is the subclavian artery that comes into the axillary artery. The brachial artery courses down to the bifurcation of the radial artery and the ulnar artery. We also occasionally see the deep brachial artery coming off the brachial artery in the upper part of the arm. The waveform patterns that we'll typically see are a high resistance waveform. This is a subclavian artery waveform showing a high resistance. This is a radial artery initially showing high resistance, but then after holding the fist tight for a few moments and releasing, we see this sort of increased inflow volume through this region, and that's pretty typical. Blood flow through the radial artery tends to be very variable depending on the vasoconstriction, dilatation of the digital arteries and the arterioles. So that's a quick review of the arterial anatomy. Now, the palmar arch in the hand is important in that it allows communication from blood flow from the radial side over to the ulnar side and vice versa. So in this diagram, we see the radial artery, ulnar artery, and then the deep superficial arch. And on this diagram, the superficial palmar arch is here as well, but it's very small. The digital arteries, there are two digital arteries usually for every digit, and these come off the palmar arch. It's important to recognize that there are patients in the population that have an incomplete palmar arch. And in this situation, this can, if a radial artery or an ulnar artery is used for a fistula or a bypass, this can create a problem in that we can reduce significantly perfusion to certain digits. So when we talk about protocol here in just a moment, I'll discuss how to evaluate the palmar arch. The venous anatomy consists of a deep system and a superficial system, but unlike the deep and superficial of the lower extremities, the superficial system carries a lot of blood volume, and the actual deep veins tend to be smaller, at least down in the forearm and the midarm. Now, the superficial veins consist of the cephalic vein, courses along the lateral aspect of the biceps muscle. This is the vein that's quite prominent in, here's our favorite weightlifter, Governor Schwarzenegger. But this is the vein that we see quite frequently on weightlifters in the lateral aspect of the arm. The cephalic vein joins with the axillary vein to form the subclavian. The basilic vein is a large superficial vein coursing up from the antecubital fossa, and this joins with the brachial veins to form the axillary veins. Usually the brachial veins are paired. Sometimes we see 3 brachial veins, but they also tend to be small compared to the basilic vein. The median cubital vein connects the cephalic system with the basilic. Again, that's a superficial vein. And when we go into the forearm, the cephalic vein continues down along the thumb side, adjacent to the radial veins, and the basilic vein courses down along the arm on the opposite side, along the little finger side of the arm. Again, we see the median cubital vein here. Now, the more central veins consist of the internal jugular vein and the subclavian veins. These come together to form the innominate vein on the left side, and we also have an innominate vein on the right side as well. There are some other smaller vessels in this region, external jugular vein, anterior jugular vein, that we won't concern ourselves with this examination. The 2 innominate veins form the superior vena cava and empty into the right side of the heart. Okay. Let's pause just for a moment and let's take a look at a live demonstration of the anatomy in the arm, the arteries and the veins. I'd like to demonstrate the normal anatomy. I'd like to start out in about mid-upper arm, identify the brachial artery and the brachial veins and the basilic veins, and then I scan more proximally, following the course of the vessels. Then I come back to mid-arm and follow them distally as well, all the way down into the forearm. I also then turn my attention to the cephalic vein on the side. We're going to initially start out scanning without a tourniquet on the arm, and then we'll apply the tourniquet and see if there's any difference in the size of the veins. So let's start the scan with the brachial artery. Here's the vasculature in the mid-arm. I can compress the veins very easily, and here's the artery still pulsating in the middle. This is the basilic vein right here. Here's the brachial artery. And these are the two brachial veins associated with that artery. The brachial veins lie right beside the artery, and the basilic vein doesn't have an artery associated with it. And the upper arm, proximal upper arm, we find that the basilic vein is very close to the artery, and it's a little more difficult to differentiate it as the superficial vessel, or at least by nomenclature. But as we scan down the arm, we find that we'll see that it actually courses somewhat away from the artery. It's a standalone. We can see it's quite a bit larger than the brachial veins as well. Now in the upper arm, this is the median cubital vein that starts to course over to the cephalic vein, and this is a continuation of the basilic vein down into the forearm. Let's stop here and just do a quick measurement. It's important not to put too much pressure on the transducer, to keep a light hand on these, otherwise you can compress the vein. I freeze it in cross section, enable the calipers. Actually, I was already using one caliper up there for a pointer, but it looks like this is about 5 millimeters. So that's a pretty good sized vein, and that would be suitable. I'll follow the brachial artery down. Here's the brachial artery here. And right in this location, the radial artery originates. This is the radial artery, and then this is now the ulnar artery, and this is diving deep. Now I've got a choice. I can follow this artery, the radial artery, all the way down, or another perhaps easier way is to actually turn your attention down to the wrist and identify the radial artery right at the wrist level. Here it is here. I'll just press on it a little bit to make sure it's not a vein. Doesn't collapse. You can see the radial veins right beside it, and I'll follow this radial artery back up carefully all the way back up to the brachial artery. And I can do the same thing in the ulnar artery as well, identify it in the wrist superficially, and then follow it back up to its confluence or its origin and the brachial artery. Now as far as the veins, cephalic vein, I'll identify the cephalic vein at the wrist level. Follow this back up proximally. There's a median cubital vein heading off to the right. And this will proceed up into the upper arm. I think we'll look at this in just a moment with the tourniquet on. But that's the cephalic vein adjacent to the radial artery, or pretty close to it. A Penrose drain works nicely for a tourniquet. And the upper arm is just primarily for the superficial veins. We don't want to get it too tight so it shuts off the deep veins. But in this case, if you don't have a Penrose drain, sometimes a large latex rubber glove will work as well. I'm going to come over now and try and identify the cephalic vein on the lateral aspect of the biceps muscle. And here it is here in the middle of the image. We can see this quite clearly now that it's dilated out because of the tourniquet. Again, this is often difficult to see on women because it tends to be very small. I'll slide around to the other side now, come out to the medial aspect of the biceps muscle, which is right here in the middle of the image. And here's the basilic vein. See, this is quite large in the forearm, And I can follow this easily down into the forearm region. Again, just in summary, this is the basilic vein here, the brachial artery, and then the adjacent brachial veins. Let's talk about the preoperative arterial protocol in more detail. Initially, we will start with the patient lying supine, and we'll obtain bilateral systolic blood pressures. And again, we compare these to be sure that there's not a 20 millimeter gradient between these brachial pressures. We'll then image the length of the brachial artery. Again, and this is in the non-dominant arm. We'll measure the distal diameter, and that's the inner diameter cross-sectionally. Then we'll also image the radial artery as well. And again, we'll measure the diameter in cross-section. That's from the inner wall to the inner wall. This part of the exam should be pretty brief. It should take no longer than about 5 minutes to accomplish this preoperative arterial scan. Now, arterial suitability is if the arterial diameter is greater than 2 millimeters. If they're less than 2 millimeters, the success of either the fistula or the graft is significantly reduced. Also, we like to see peak systolic velocity of greater than 50 centimeters per second. We also note calcified segments within the artery. This can affect the surgical procedure. And also, we'll test the patency of the palmar arch. The palmar arch can be tested subjectively by using the Allen test. That's a method in which we compress both the radial and the ulnar arteries and have the patient squeeze their hand a few times to exsanguinate blood out of the hand. And then we release alternately the radial artery, and then we repeat and release the ulnar artery, and we look for perfusion to be resumed within the hand. This is actually an easier test or more objective if we can use some type of physiologic testing method, for instance, photoplethysmography or PPG. In this next slide, we see PPGs applied to the index finger and to the fifth digit. We acquire waveforms at a slow sweep speed of the perfusion to these two digits, and then we compress the radial artery, and we look for the changes, if any, in the perfusion to these two digits. In this case, when we compress the radial artery, both the index finger and the fifth digit go flat line, indicating that there's significantly reduced or no perfusion to those digits. When we release the radial artery compression, we see blood flow come back to the pre-existing compression levels. When we compress the ulnar artery, as demonstrated in this cartoon, we see that there's no change taking place through the perfusion to the left index and the fifth digit as well. So then this indicates that this particular patient has a radial dominance that's occurring, so that there's little perfusion coming to the hand from the ulnar artery. It's all from the radial artery. So this patient would not be a candidate for this particular radial artery to be used in a fistula or a graft situation, because if there's a cessation to flow in this radial artery distally, it can result in ischemic symptoms in the digits. Now, as far as the preoperative venous assessment, we scan the deep and superficial veins for any obstruction or previous thrombosis. Now, it's difficult for those of you who have scanned proximal veins for venous thrombosis. You know that it's difficult to evaluate the innominate veins bilaterally because they tend to sort of lie underneath the clavicle. So what we can do is to compare carefully the waveforms in the subclavian vein, either just before the clavicle or just proximal to the clavicle. This diagram on the right, or this example, shows a normal right subclavian vein waveform showing pulsatility reflected from the right side of the heart, as well as respiratory phasicity or changes taking place. The opposite side, the left side, however, has a waveform that's significantly different. In fact, this patient on the left side had a thrombosed innominate vein, and blood flow was coursing in an antegrade direction in the internal jugular vein as a collateral pathway. So comparing these waveforms is important. They should look pretty identical, again, with the patient supine, evaluating the subclavians in the same locations. They should be very similar. Now we proceed to image the cephalic vein and the basilic vein, and we evaluate the anatomy and whether they're present or not. We also measure the vein diameter in the forearm and the arm. There are a couple of different methods for this. Some investigators and clinicians suggest using a tourniquet, like a Penrose drain that's put up on the upper arm to dilate these veins. If the cephalic vein is 2 millimeters or greater without the tourniquet, then the cephalic vein is suitable for access procedure preoperatively. If with the tourniquet, if it's 2.5 millimeters or greater, again, that's a suitable vein for the procedure. Again, as mentioned before, then we evaluate the vein outflow tract for any obstruction or thrombosis. This is critical in preoperative assessment. Now, a normal vein exam, absence of stenosis or thrombosis. We have patent deep veins in the upper arms. We have 2.5 millimeter residual lumen for fistulas. And if there's a graft planned, the diameter of the veins, the cephalic or basilic veins, should be 4 millimeters or greater. Again, that's with a tourniquet applied. Now, in the preoperative exam, we like to evaluate the non-dominant arm on the patient because that's the one that's most likely will be used for the fistula or the graft implantation. If we evaluate the non-dominant arm and it's unsuitable, either on the venous side or the arterial side, then we evaluate the other arm. Some laboratories evaluate the arms bilaterally. What we find to save time and effort, we tend not to evaluate the other arm unless the primary arm is unsuitable. Now, let's talk about the postoperative assessment. This is a different examination altogether. This is following the implantation of the graft, PTFE graft, or the creation of a fistula. Usually the fistulas and the grafts are allowed to mature for anywhere from 4 to 8 weeks, and then they'll start to be used for dialysis. There are a number of complications that can arise during dialysis, and duplex ultrasound is an excellent tool for determining stenosis occlusion or other complications associated with a functioning or nearly functioning hemodialysis access graft. For the postoperative assessment, should be kept in mind that there are up to 40% of these grafts or fistulas, there's an initial failure rate, so the grafts will not go on to maturity. One of the most important pieces of information for us prior to scanning the graft or fistula is to obtain the surgical information. Just a quick anecdotal story. I spent 45 minutes scanning someone's loop graft down on the forearm and found it was totally occluded by the time I figured out the hemodynamics, etc. And I was quite proud of myself that it came to a pretty quick determination of that. But as I was about to send the patient home, she suggested that maybe I should take a look at the other graft, the one in her upper arm. So it's not unusual for these patients to have more than one procedure. Sometimes these often they fail and additional grafts and revisions are put in. So having the information prior to the duplex scan is tremendously helpful and will save you an awful lot of time because these can be quite complicated and the surgeons can be quite creative, and as I mentioned, each one of these grafts or fistulas tends to be unique. Some of the indications for duplex imaging of hemodialysis access is difficult cannulation or thrombus aspiration during hemodialysis. If the venous pressure is elevated, greater than 200 millimeters of mercury, this can be an indication of failure as well. Unexplained urea reduction, less than 60%. Additionally, access recirculation of 12% or greater. This is one that's sort of called the thrill is gone. Most of these fistulas and grafts have so much blood volume that it actually causes a vibration in the tissue and a vibration in the graft. And when the thrill is gone, that's also an indication for duplex imaging to determine any possible graft lesions or problems. Also, palpable perigraft mass, it's important to determine whether we're looking at aneurysm, pseudoaneurysm, or seroma. Additional complications associated with these hemodialysis access devices is thrombosis, stenosis, infection. This mostly occurs in synthetic grafts and less likely in arterial venous autogenous fistulas. Also arterial steel, and this can create digital ischemia. Distal venous hypertension can create decreased perfusion in the hand. Also aneurysms and pseudoaneurysms, and we'll talk about these a little bit later in the presentation. The scan protocol, after we obtain the surgical history, is to start out in the transverse plane. You can also note the needle tracks along the arm to sort of help you guide the course of the graft or the vein fistula. I might mention too that once the fistulas are created and the grafts, that there's high volume in all of these. It becomes more difficult to distinguish an artery from a vein, so following needle tracks is useful to determine the course of the vein. We use a high-frequency transducer, somewhere between 5 and 10 megahertz. And also, I think it's important to allow sufficient time for the exam. 45 minutes to an hour is not uncommon for these procedures. I'd like to start out with a general survey, just to find out where the graft is, what the origin of the graft, and where the distal anastomosis is, and ditto for the fistulas as well. So we scan the upper brachial artery to the distal radial artery. I identify the graft or fistula origin, and then I scan the course of the graft or the fistula, and then I also scan the course of the outflow veins. This is important post-operatively as well as we mentioned in the preoperative exam. One point caveat that I'd like to give you is that, especially on loop grafts in which you have blood flow going down the arm in the graft and then coming back in the arm, it's very important to determine flow directions. So to standardize the scan procedure, I would recommend that you set up the image so that the hand is always to the right of the screen, as we demonstrated here on this diagram. This way, we know that blood flow that's going from left to right, say in this case in a radial artery, that we know that this is a steal going on. This is a retrograde radial artery flow that's distal to a fistula or a shunt, and it's causing a steal from the radial artery. So without this image orientation, it's difficult to figure out flow directions. The scan protocol, what we measure and record are peak systolic velocities, and we obtain these in the inflow artery, the brachial or the radial artery, depending on the site for the graft or fistula. We also obtain these measurements at the proximal, mid, and distal graft, and then also at the anastomotic sites. We measure and record peak systolic velocity in any region of flow disturbance or stenosis that's seen in the graft. And then we also obtain velocity in the outflow veins as well. Now, an important point here is that, as I mentioned, sometimes these grafts blood flow can reverse in the artery distal to the anastomosis, so it's important to evaluate those arteries and then look for flow direction to determine if there's any steal taking place. And I've got a case that we'll review just a little bit that shows a steal in a radial artery situation. The graft evaluations, this is just a diagram showing the sample sites. We evaluate the arterial inflow. Again, the hand is to the right here. This is distal. We evaluate the proximal anastomosis of the graft or fistula. We survey the entire graft, taking periodic measurements, particularly the outflow region. And then we evaluate vein flow, and particularly in direction for the outflow track. And then additionally, distal to the anastomosis in the artery, again, noting flow direction. The usual problem site within grafts is at the distal anastomosis or the efferent venous site. This is where the graft comes back into the vein, and it's very common for intimal hyperplasia to develop right along this site because of the increased shear force that takes place from the high volume arterial flow striking the arterial wall. So this very frequently causes a significant stenosis that goes on to thrombose the vein. Here's an image of some neointimal hyperplasia that's occurring in a basilic vein just close to the arterial anastomosis of a graft. We can see the thickening of the intima right through here, which is pretty unusual to see in a vein. Normally we don't see the vein wall in ultrasound. So if this goes on to significantly stenose the outflow vein, then a whole plethora of different hemodynamic situations occur. Now, additionally, we follow the outflow veins to the central veins because these venous thrombosis can occur in these veins and intimal hyperplasia distal to the anastomotic sites. We also look for any kinking in the graft or extrinsic external compression that can be caused by pseudoaneurysm or some type of a mass associated with the fistula or the graft. In addition to measuring peak systolic velocities in the sites that we had mentioned, we like to evaluate the flow volume in the graft or the artery leading into the fistula as well. And to accomplish this, we select a relatively clean site, usually in the mid-graft. This is a site that has not been used frequently for hemodialysis because often there's some scarring that narrows the internal diameter of the graft at those sites. So we're trying to select a clean site based on the B-mode image. We then turn to the cross-sectional image and we obtain a lumen diameter measuring the inner wall to the inner wall. Then we obtain a flow volume measurement and we expand the sample volume so it's the entire width of the diameter of the vessel in the long view. Now in this case I've used color Doppler, but it's best to turn off color Doppler when we're actually measuring the diameter because the color can sort of obscure the walls somewhat. So in the longitudinal plane we obtain several spectral waveforms, and we can also use a slower sweep speed on the Doppler to accomplish this. We then calculate time average velocity with the software that's located on your ultrasound system. Now, fortunately, the software in most systems calculates this flow volume measurement for us automatically, but generally flow volume is area, and this is determined from the diameter measurements. It's automatically converted to area, times time average velocity times 60 seconds, or area times average maximum velocity, and this will give us flow volume in milliliters per minute. For fistula flow volumes, the fistulas are difficult because of the variability in the vein size. An earlier diagram showed a sausage-like sort of affair, so it's difficult to get a good diameter measurement. For that reason, it's recommended that we obtain flow volume from the feeding artery, whether it be the brachial artery, the radial, or the ulnar artery, particularly if it's the brachial artery. Because the majority of blood flow coming down these vessels is going into the fistula it's going into the fistula, with perhaps 10% going on to the hand. There's some published guidelines in terms of flow volumes for grafts. Of milliliters per minute to 300 or less usually results in very poor dialysis. There's a value that's been published saying that somewhere between 500 to 800 milliliters per minute, that's sort of marginal, and that there's an increased risk for graft thrombosis if it's in that region. So I just compromised here and said less than 650 milliliters per minute, there's an increased risk. And of course, this varies quite a bit from patient to patient. Now for fistulas, fistulas have been shown to survive at much lower flow volumes than grafts. But again, less than 300 milliliters per minute usually results in poor dialysis. 300 to 500 milliliters per minute is usually borderline for fistulas, but if it's greater than 500 milliliters per minute, that's usually pretty good, and that's okay. That's not cause for concern. Now, I might mention that there are some grafts that have stenosis, but the volumes are maintained above these thresholds, and they'll last considerably longer than those with the lower volumes. For graft stenosis concerning peak systolic velocities, The criteria indicates that a 2-to-1 increase, that is a focal velocity acceleration taking place anywhere within the graft or in the feeding artery into the graft or in the distal anastomosis. We also like to see, as in all stenosis, the severe post-stenotic turbulence to confirm the fact that there is at least a 50% stenosis. There's criteria that have been established for greater than 50%. This was published years ago in the Journal of Vascular Surgery. Generally a 2-to-1 increase from the pre-stenotic to the maximum stenosis, and then also peak systolic velocity that exceeds 300 centimeters per second, along with post-stenotic turbulence, suggests a greater than 50% diameter reduction. This is in a graft. As far as the fistulas go, a 50% stenosis usually results in peak systolic velocities exceeding 300 centimeters per second plus a 3-to-1 ratio. That is the velocity within the feeding artery, in this case radial artery, compared to the stenotic region within the fistula. Also, there's some values that have been demonstrated for outflow cephalic vein stenosis. If there is a 3-to-1 ratio within the vein, that suggests a 50% stenosis as well. Now, as of interest, published a few years ago in the Journal of Vascular Technology, a group from Holland evaluated 87 new fistulas in grafts. And they found that in 72% of the fistulas and 82% of the grafts, there was a 50% stenosis that developed within 1 month. They also found that there was no significant relationship between the stenosis and graft occlusion. So the fact that there are a number of these patients have 50% or greater stenosis, it doesn't exactly correlate to difficulties perfusion. In fact, it's quite common to see this on anyone that has a graft longer than a few months. Let's turn to an example of a patient that has a left radial artery to basilic vein. This is a straight PTFE graft of 6 millimeters, and the patient underwent a recent revision. Again, we've oriented the images so that the hand is to the right of the screen. This is the radial artery here in the B-mode image, and this is the graft coming off more superficially. Again, these grafts are usually established superficially, so they don't have to go deep to during hemodialysis. You can see from this color image that the flow is very, very chaotic in these regions, and aliasing is sort of the name of the game. We have to use very high PRFs because the flow volumes and the velocities tend to be quite high. In the mid-radial artery, proximal to the graft, we see flow that's very uncharacteristic for a typical radial artery, and that we have a very low resistant flow. Remember that the radial artery flow normally is high resistant, except if it's providing blood flow to a fistula or a graft. Then we have high velocity and low resistance. Peak systolic velocity here is 180, end diastole is 103, and this is in the artery feeding the graft. In this case, we've obtained the diameter measurements here on the graft. Again, even though we're just showing in this case from the longitudinal view, the meaningful data here comes from the transverse measurement without color Doppler on. We've obtained time average velocity over 4 waveforms, and the time average velocity is 78 centimeters per second. This results in a flow volume calculation of 1,317 milliliters per minute. So that's pretty good in these graphs. There is actually, I didn't mention in the criteria, but there is some concern that if the flow volumes are too high in these graphs, that can result in increased right side heart pressure and complications of a cardiac nature. So, and this usually occurs if we see flow volumes getting above 1,500 milliliters per minute. The distal graft, we're at anastomosis back into the basilic vein. The proximal or the distal graft just before the anastomosis, the velocities are 274, and then we'll walk the Doppler cursor right through this region. We didn't see any flow disturbance in this region, nothing significant. And when we come into the basilic vein on the anastomotic side, just past the anastomosis, peak systolic velocities are 294. So they've gone up just slightly, but certainly not enough to suggest that there is stenosis or any problem in this region within the fistula, the graft. Now, the distal radial artery, and this is interesting, this is distal to the graft. We see retrograde flow in the radial artery that's coming back to feed the graft. So there is a steal taking place, an arterial steal in the distal portion of the radial artery. We evaluated the ulnar artery just to see what the flow looks like here, and the flow in the ulnar artery is actually low resistant flow as well. So the ulnar artery is not only supplying some blood flow to the hand, but it's also supplying blood flow to this graft by retrograde flow in the radial artery. We compress the radial artery and we could watch the ulnar artery, and we could watch the radial artery flow change directions. So it's interesting hemodynamics. In addition to stenosis and thrombosis within the graft or fistula itself, it's also important in the postoperative procedure to look for other complications that can occur. And these include pseudoaneurysm. If the pseudoaneurysm is less than 1 centimeter in size, usually there's no problem. If they're greater than 1 centimeter, then these can be problematic. Also, we look for graft disintegration, usually at the anastomotic sites. This type of a failure can result in pseudoaneurysm as well. Here's an example of a small pseudoaneurysm. This is the graft and transverse view, and this is a result from the hemodialysis access needle actually going all the way through the graft and creating a small pseudoaneurysm on the deeper aspect of the graft here. So we see pseudoaneurysms on the near field and the far field side of these grafts and fistulas as a result of needle placement. Any palpable mass or structures seen adjacent to the graft or the fistula should be evaluated as well with color Doppler to determine if we're looking at an aneurysm or pseudoaneurysm. This is a perigraft mass that appears on our ultrasound image associated with a radial artery hemodialysis access graft. It appears as though there's no flow in this region. It's quite large and protruding and actually displaces the artery somewhat, but it's not compressing the artery. So in addition to determine whether this is hematoma versus aneurysm or pseudoaneurysm, we look carefully to determine whether there's any extrinsic compression from these structures on the adjacent vascular arteries or veins. Other complications include infection. This can be of the operative etiology or can be caused by the punctures or the hemodialysis. Also from wound infection, which is not uncommon for hemodialysis patients. The ultrasound appearance of these infections tends to look like it's a fluid collection in a mass associated or adjacent to the graft or fistula. Also, there's sometimes a swirling appearance within the infection, but keep in mind that this also can be a seroma, which is not uncommon in Gore-Tex graft hemodialysis access grafts. Now, another interesting complication is venous hypertension. This can result because of outflow stenosis with concomitant arterial inflow disease. This fistulogram was taken on a patient that had a hand that actually had stasis dermatitis and was swollen and actually looked very typical of what we see in venous insufficiency down in the ankles or on the foot. The skin coloration was very much the same. This is the distal end of the loop graft. It was a brachial artery to or basilic vein graft, and the fistulogram demonstrates a stenotic region right in here through the basilic vein. There was retrograde venous flow taking place going back down into the arm. The patient had significant swelling in the hand. So in addition to evaluating, particularly on these patients with the outflow stenosis, this patient also had a problem with the basilic artery or the brachial artery just distal to the anastomosis. Now, one other artifact of ultrasound is that some material is impenetrable. This is a 2-day-old Gore-Tex graft or PTFE graft in which there's still air within the wall of the graft. After these mature for a while, this air goes away, and then it's penetrable by the ultrasound systems. But initially, when these grafts are installed, often we see this artifact. We refer to it as rain. It looks like little Christmas lights all the way across the top of the graft, and it's essentially impenetrable to the ultrasound. So it's this artifact is sort of doesn't change with PRF change. It's there with low PRF and with high PRF as well. So it makes it more difficult to determine whether the graft is occluded. Here's a longitudinal view of this 2-day-old graft as well. Again, no penetration through this region with color Doppler, but the question is the graft material blocking the Doppler signal, or is the graft actually thrombosed? So we sometimes have to focus on the inflow and the outflow that's taking place. This graft has a radial artery flow leading into it that's very high resistant. And this is very atypical for a graft that's functioning because we'll have low resistance and high diastolic velocity. Also, the outflow from the graft, in this case the basilic vein, shows very low volume and the vein has not been arterialized. So these are some clues that we can use for those grafts that, PTFE grafts that are freshly inserted, and also for these new polyurethane grafts which are impenetrable to ultrasound as well. We can evaluate the patency of these by the inflow arterial and the outflow venous tract. Now, a question that's frequently asked is that can you take a blood pressure on an arm with a fistula or a graft? And the answer to that is no. It's recommended that we don't obtain pressures. If we can obtain digital pressures, however, particularly if there's any concern about ischemic digits. That's a very common method to obtain digital pressures. So in summary, the preoperative assessment is very important. It has been shown that with the information of the venous and the arterial system prior to the surgical procedures, that the success rate of these fistulas and grafts is much higher and the longevity is much longer. Also, the postoperative assessment is very important for, particularly if there's any indication for the study, for promoting patency in these grafts. Procedures can be performed prior to the grafts thrombosing. I will recommend once again that these are very challenging exams in the postoperative situation, so bring all your problem-solving skills and allow yourself plenty of time. And enjoy the hemodynamics. Thank you very much.